What's up, everybody? Welcome back to my channel. It's me, Kendra, new here. Who's this? It's me, and I know, guys, I have been slacking on uploading videos. It is because coming back from vacation and then going on another mini vacation, like, I am completely not in my routine. As a matter of fact, I have no routine. So I'm trying to get myself back on track to where I can post at least 2 videos, preferably 3 videos a week. So it's only up from here. I will be doing better. In this video today, I want to talk about medication errors that I have made in my nursing career. So let's go ahead and jump into the first one. I've been a nurse for about 2 years, so I was still technically a novice, and I was working on a busy IMC unit. When I say busy, like super busy, the patients were super sick, acuity very high, and also the ratio was supposed to be a 3-to-1. However, we always had 4 patients. 4. And that was just madness. This specific IMC in any other hospital would have been considered an ICU. The only thing we did not take were vented patients, and certain drips we could not manage. But when I tell you that IMC was busy, super busy. Also, the demographics that we served, like the hospital served, were super sick. For example, a patient could never just come in with 1 or 2 things wrong. Any patient that gets admitted, especially to the IMC, had at least a minimum of 4 things wrong with them. It can be that the patient was found confused, wondering, they missed dialysis for like 3 days. They came into the emergency room. They were having stroke-like symptoms. The blood sugar was in the 40s. The patient needed a unit of blood because the H&H was low. It's just like so many things that you're managing. And sometimes it's very hard to even connect the pieces on the patients because it's so many things going on. So many different doctors consulting. It's just like, what is happening? My first error happened when I was taking care of a patient who was ordered vancomycin at about 3 o'clock in the afternoon. And it was a load-in dose of vancomycin. So it came in a 500 ml bag. Now, when the medication came, I was like, I need to go to lunch because I had been ripping and running all day. All I had was like a cup of coffee, and I think I ate a few peanut M&Ms. You know, the mini packs? I always carry, like, I used to carry M&M peanuts with me because I'm like, in case I don't get a chance to stop and eat, at least I have something that has a little bit of nutrition and a little bit of sugar to sustain me and keep me going. So I had been ripping and running all morning. By the time 3 o'clock came and that vancomycin arrived, I was done. I was hangry. I had an attitude. I just wanted to go on break. So I said, before I go on break, I'm going to run into this patient's room and I'm going to hang the vancomycin because clearly infectious disease is following him, and they decided that he needed this load-in dose. So anyway, I go into the room. The patient has an IV pump and pole. I proceed to set everything up, and I connect the patient to I connect the tube into his IV, and I program the pump, and I'm like, okay, good to go. I am going on my break. Please don't call me. I will see you all when I come back. As I was coming back from lunch, I'm walking up the hallway to the unit, and I see, like, in front of my patient's room, I noticed that the pharmacist is out there. There's 2 residents, and then there's the attending physician. So I am like, well, the hospitalist, which is the attendant. So I was like, what are they doing in front of my patient's room? I'm pretty sure they want something from me, but I'm not trying to do that right now. So I made a quick left. The moment I made a left, my Vocera goes off. And Vocera is the device, I'm trying to see if I have it here. But anyway, Vocera is a device that we carry that we use to communicate with each other. Like, you can get phone calls on it, you can call people on it or whatever. So my Vocera goes off, and it's the pharmacist. And I was like, hi. And she's like, hi, Kendra, I saw that you were just coming back up the hallway. Do you mind when you're done to please come to room, I think it was room like 15 or something. So I said, okay, sure, right? So I put my lunch bag away and I walk over to room 15. I get to room 15. I'm like, okay, what is going on? They're like, yeah, we ordered vancomycin for this patient, and it was supposed to run in over 2 hours. However, we were coming to see the patient. We wanted to talk to his wife about some of the issues she'd been having. And we noticed that the bag of vancomycin had already infused. So I'm like, I don't know. I hung it. I programmed it in the pump. I punched in the numbers, and that's it. They were like, yeah, we're not sure exactly what's going on. The next thing I do is I look over at the patient, and I'm like, he is bright red. Come to find out, the patient had a vancomycin allergy that the doctor missed, pharmacy missed it, and I surely missed it, because guess what? I'm ripping and running. You think I really have time to check? Like, I know it sounds bad, and I know it's part of the medication administration rights, but the reality is, oftentimes you're so busy, that is the last thing on your mind. So my patient is laying in the bed, and he is bright as a tomato, like red. So for those of you who are nursing students, one of the things with vancomycin, if it is infused too quickly, the patient can develop Redmond's syndrome. So the patient did develop that, and he was red from his torso all the way up to his chest. Some of his arms, like his outer arms, were red, and I was just like, oh. So this is what Redmond syndrome looked like. It was my first time ever seeing it. Anyway, the doctor and, you know, the residents, they were pretty cool. They were like, hey, we put an order in for, I think, Tylenol, Benadryl, and Solumedrol. They were like, just give him that cocktail, and we'll just monitor him, check his vital signs every hour for the next 2 hours. And, you know, once his airway isn't compromised, then, you know, we'll just document it as we'll do an incident report that it was an error or whatever, right? As far as the allergies is pertained, not the dose going in too fast, right? So I was like, okay, cool. Now, the other thing is that the patient's wife was there, and she did not have a good rapport with the doctor because she had been arguing back and forth with the doctors. Apparently, she had called them stupid in the past. She was very disrespectful. Apparently, this lady used to be a physician back in Russia when she was younger. So she had some medical knowledge, and she just felt like they were mismanaging her patient. Not her patient, her husband. And then now here she is with all of her medical knowledge with her husband being bright red. So now she's like furious. But because of the poor rapport and because of her bad behavior, the doctors and the pharmacists actually believed, or they thought, that she had meddled with the infusion pump when no one was in the room. Because when I first hung the med, she was not there. When I went to lunch and came back, she was there. So they were like, who knows? The wife probably messed with it. I mean, she does have like not medicine knowledge. She probably did that to cause him to have a reaction. But I was like, listen, I don't know anything about that. So the shift ended, thankfully, uneventful. The patient was stable. We did not have to escalate care. So I was pretty happy about that. On my way home, it's a habit of mine where I don't listen to the radio on my way home. On my drive home, that is when I reflect on my day, and I reflect on all of the actions and the decisions that I made throughout the day taking care of patients. Like I run through my brain and I say, all right, Kendra, next time start a little bit earlier. Or next time, give the meds an hour earlier. Don't wait until close to when it's due. Like, I'll just go through my day and say, all right, you need to improve on this, or you could have done this, or maybe next time do this, just to kind of help improve my nursing practice. So obviously, I'm driving home and I'm thinking about this medication era. And I'm like, how the heck did that vancomycin get infused so quickly? Because unlike the physicians, I didn't believe that lady meddled with the pump. Something told me she wouldn't do that. So I'm trying to figure out, well, what the heck happened? And that's when it dawned on me. I'm like, yep, it was your fault. You did it, Kendra. What had happened was I was so hangry by the time I got the 500 ml bag of vancomycin that when I hung it, rather than using the library within the Alaris pump to program the medicine, so that way the pump figures out the rate and the calculation, which is already pre-programmed in the pump, I overrode those measures because guess what? I did not have time to be going through the menu looking for V, then pressing vancomycin, then punching in the dose. I said, skip that. I looked at the label on the bag and I'm like, all right, 500cc bag goes in at 250. Cool. When I programmed the pump, I programmed it incorrectly because I did it manually. So what I did was, it was a 500 ml bag. I should have programmed the rate at 250 mLs an hour. Instead, I programmed the rate at 500. So he got the bag of vancomycin in an hour instead of 2 hours. And that was my error. The other error was I did not pick up on the allergy. Like, I completely missed the fact that this man had a vancomycin allergy. Now, you all know, or if you don't know, what they tell us nurses is that even if the physician orders something and it gets approved by the pharmacy, you as the nurse get it, you're like the last check. And ultimately, nurses usually take the fall for errors that are made because they're like, you're the nurse, you're the one giving it, and you should have gone through your medication rights. Now, how many medication rights are there now? I think when I was in nursing school, it was TRAMP D, time, route, amount, medication, dose, and person. And I think now they've added some more components to that whole right time, right place, right person, right medication, all that stuff. I think it's a little bit more now. So basically, I did not, as a nurse, do my due diligence in check-in. Therefore, I missed the allergy, the vancomycin allergy, and then I had the nerve to override the computerized the program and enter manually. So it was my fault. But I didn't realize it until I was on my way home and I was reflecting on how the heck did that happen. But let me tell you what I learned from that situation. Never, ever, 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 ever will you find me manually punching in medications into the Alaris pump. Nope. Not anymore. I learned my lesson that one time. I can honestly say that I always use the library based on that situation, because I'm not trying to get jammed up. What I have not improved on, to be honest, is checking the allergies, because I feel like the hospitals that I've worked in, they have a pretty good, robust pharmacy like department where they usually catch it. But obviously in this situation, pharmacy missed it. So it's something that I'll say to myself every once in a while, like, girl, you still ain't checking for them allergies, and you really should, because you just never know when pharmacy or the doctor missed it. So I do still, at this point in my career, need to improve on that. But you don't ever have to worry about me not programming that Alaris pump. I program it all the time because, like I said, I'm not trying to get jammed up. Anyway, let me go on and tell you about the other situation where I made an error. And I guess we can consider it a medication error, and I'll tell you why. Again, I was working on the busy IMC unit. This day was crazy. So I had 4 rooms, but one of them was empty. So I had 3 patients and I had an empty room. Of course, the room is going to be filled in no time. I get a phone call from the charge nurse. Hey, we're giving you a patient. The patient came in, H&H is low. They started transfusing her in the emergency room. We're going to put her in this room, so you're going to have to continue the transfusions. And I'm like, but I'm already transfusing another patient, right? The charge nurse is like, oh, well, we don't have anyone else to take the patient, whatever. Okay. Now, at that point in my career, I had been a nurse, again, for like maybe a little over 2 years. So I still consider myself to be a novice, meaning that my advocacy for myself was definitely not developed. Like, I did not know how to speak up and say, no, that's not going to work for me because my license is on the line. It's a patient safety issue, and I think we need to probably switch the assignment or have another nurse take one of those, give me her patient, and she takes this new admit. That way I'm not transfusing 2 patients at the time. But like I said, I didn't speak up, and I said, oh, okay, sure, fine. So I get this lady from the emergency room who I have to transfuse. Meanwhile, I'm transfusing another patient that I think has to go to dialysis later on in the day, or it's some kind of craziness going on. So obviously when a patient is being transfused, CBCs, complete blood count tests, laboratory tests are being ordered. So I know when it was a couple hours later, and I think one of my patients, the one that was supposed to go to dialysis, I finished transfusing her, and the physician wanted a baseline to see if at all, if it made a difference in her blood count. So he put in an order for me to draw labs. And then at the same time, I had to draw labs on the other lady from the emergency room. So long story short, I drew labs on the both of them. No, that's not what happened. I drew labs on the lady who needed to go to dialysis, but I used the label from my new admit from the ER. All because you really shouldn't be transfusing 2 patients at the same time. That's really a safety issue. And then also I had 2 other patients on the busy IMC unit. So when I sent the blood work, I remembered the physician. He was sitting at the station when the blood work resulted. And he was like, oh, her blood count looks amazing, or something to that effect. And I was like, how he know her blood count is amazing? I didn't send blood on her. But he was like, look, Kendra, her blood improved. It was this and this and that when she came in the emergency room, and now it's this number. It was something like that. And I was like, I didn't send blood on her. And he was like, well, there's a blood result here. I said, no, my mistake. I said I labeled the blood work incorrectly. I meant to send blood on the other patient, but I used the wrong label. So he was like, oh, okay then. So we ended up calling the lab. We called the charge nurse, and the doctor was like, it's not a big deal. Let me go ahead and reorder it. I'll have the lab cancel out these results because it's erroneous. It's for the wrong patient. So I'll go ahead and we'll just have the lab cancel out these orders, these results, and that way draw it and just make sure that you label it correctly so that way we can get accurate results. Whew. So thankfully, another situation that did not have to get escalated because it was just a mislabeling issue, and my charge nurse was very supportive. The doctor was very understanding and supportive because obviously they both knew that, well, you are transfusing two patients. It's a possibility that you can mislabel or make an error. Like, things like that happen. That's the reason why we try not to give a nurse, especially on this busy IMC, two patients that are being transfused at the same time. It doesn't, mistakes can happen. So the one thing about that situation I will say is, because I tend to have pretty good relationships with my coworkers as well as the physicians that are taking care of the patients. I introduce myself to the doctors. I usually, because when you're not working in the ICU and you work on like IMC and med surg, the physicians don't really engage with the nurses. But I have always made it my duty to engage with the physicians. Like, hi, I know you have room 6, 7, and 8 today. I'm the nurse for the patients. Like, can you just let me know what's going on, if you're going to put in any new orders, or what's the plan for the patients? I always would ask, because I just hated the fact that doctors will come on the floor and not like give the nurse a heads up of anything that was happening. Too often I had gone into patients' rooms and the patient knew more than I knew what was going on with their plan of care. Like, the patient's like, oh yeah, I'm leaving this afternoon, fully dressed. I'm leaving this afternoon. The doctor came in and told me I can get ready to go. And I'm like, the doctor never told me that. So I had a good relationship with my charge nurse, my coworkers, as well as the physician. So that worked out, well for me. For me, the biggest lesson that I got out of the situations is not to rush. So when it's time for me to do medication administration, I like very minimal distractions. I don't take phone calls. I don't engage in conversation with my coworkers when I'm preparing meds, because it's so easy to get distracted. Again, I told you all, I am forever using that Alaris pump to program my IV medications. And also, if I'm transfusing two patients at a time, although I don't think that's ever happened to me again. Not even in the ICU, I've had to transfuse two patients at the same time. And maybe in that situation, what I have learned is maybe to speak up and say, this is unsafe. Can we switch? Or you charge? Can you take care of sending the labs? That way I'm not like all confused and all over the place, running around like a chicken with no head. So those are the lessons that I have learned. As we all know, medication administration is one of the biggest responsibilities of nurses. And so we really have to advocate for ourselves and speak up. I will be tuning out. Like I said, I just got home from work not too long ago and I decided to jump on and get this video done. I am tired. Today was rough. I almost wanted to quit, but I'm going to take a shower and go to bed.